right, we're going to finish preterm labor, and we're going to talk about the nursing care. So home care versus hospital care, because sometimes some moms just are not admitted to the hospital, and we can teach moms the signs and symptoms of true labor, and we're going to go through all this checklist. And some of them are then actually triaged to the hospital. It's determined by the progression of the preterm labor. Now, what we want to teach them, especially check for, and we can tell them how to check for, but we also want to check for side effects of the tocolytics. So in this situation, the mom's being tocalized. Toco, contractions, lytic, getting rid of them. So we can look at things like nifedipine, indocin, mag, terbutaline. Lots of side effects, correct? So we will doing an NST on her, EFM, specifically NST, the type of EFM, INOs, daily weights, check for what? Fluid retention, voiding frequently, because remember, a distended bladder in pregnant women causes uterine irritability, maybe wanting it to go into contraction, so that's not good. Push-peel fluids, always stay hydrated, can go into preterm labor. Lie on left side, want to avoid what? Supine hypotension, bathroom and bed rest on them, and bathroom privileges. So some are strict bed rest, some have bathroom privileges depending on their progression. Relaxation techniques, we talked about that in labor and delivery, how the mind and the over matter is so huge, and it can affect what? Preterm labor because of the stress and the cortisol. Diversional activities, remember, the GI support, very, very important, so she won't what? Strain. Avoid sex and breast stimulation, so it won't put her into labor. Hazards of immobility is huge. If she's going to be on strict bed rest, I want you to review, oh yeah, that's right, what are the effects of laying in bed too long? Do you remember all that? So that's part of first semester that you need to review. We'll probably keep her IV fluids, LR at least, tocilizer, either IV route or PO route. We sometimes do a UA CNS, rule out UTI. We do a culture and sensitivity. We rule out infections. Group B beta strep is huge. We're going to talk about it right below us on PROM, premature rupture of membranes. So it's huge. If she is in some sort of infection, whether it's the source is a UTI or a vaginal culture, and we see it coming back as positive, it can, again, put the mom into preterm labor. Group B beta strep, now you have to remember, you think to yourself, oh, it's right, an infection, maternal infection lecture, it's a huge thing. Not so much the infection on the mom, but an infection on the baby, neonatal sepsis. But any type of level infection, sometimes STIs, can cause a mom to go into preterm labor. GBS, less likely for mom, but huge effects on that baby. Again, toxicology screen, remember, maternal substance abuse can put her into preterm labor. Psychosocial support, and if the preterm labor increases, delivery is dependent on maternal and fetal distress. So I want you to really review preterm labor. It's something that we talk about that a lot. We see it a lot in the maternal population. And we also want you to review what? Hemorrhage, especially postpartum hemorrhage. That's huge. And then it comes along with that is DIC. Okay, let's talk about premature rupture of membranes. It's not passive range of motion. It's premature rupture of membranes. Now, I know students ask me this a lot. Okay, so I know what PROM is. We've heard of that. Usually the mom has ruptured typically within 18, has been ruptured for as long as 18 to 24 hours. And we got to do something about it. Remember, on some moms, it's a huge gush, and some moms, it's a slight trickle. And they got to triage her and decide from that what to do with her. And remember, if it's a small little trickle, the baby, if it's presenting vertex, can what? Can plug up the little hole of the amniotic sac, and she may stop rupturing. So it doesn't mean she automatically delivers. And then also we know the amnion cells closest to the baby produces amniotic fluid, plus all the extra fluid that's on board on mom. So premature rupture membranes is not a done deal for delivery. You got to remember that. There's a lot of etiology unknown. A lot of it's chorioamnionitis, which sometimes happens. And then I want to impress upon you, you're thinking, okay, so what is the most potential highest risk for a POM? It is ascending infection. we hear the word amnionitis. In some books, we hear the word, in your textbook, chorion amnionitis. And that is basically the microorganisms ascended and basically set up shop. We learned that in maternal infections, dark, moist, and warm. So we really got to rule out that. It's huge. And then obviously it turns into sepsis. A lot of these other things that we've talked about can rupture the membranes. It's very short here, thinking, well, how do I know it is amniotic fluid? Now we remember we talked about the grid when mom is pregnant. 3 things. Is she having pain? Not necessarily, unless she's what? Having preterm labor. And the most common cause is preterm labor. So remember the 3 criteria. Is she having pain? Or maybe if she has preterm labor with it. But typically with just a plain isolated prom, not necessarily pain. Does she have bleeding? Not necessarily, but does she have discharge? Vaginal discharge is amniotic fluid. And I impress upon students upon this is that when she thinks she's ruptured, or she'll say leaking fluid, we have to decide between, is it urine or is it actually amniotic fluid? And as you well can figure out, amniotic fluid is basic. Urine is acidic. So they can check for the nitrogen test. They just basically, maybe in the clinic, in the doctor's office, just test to see if it's what? More alkaline. And then what we have, it's in some books, it's called the Ferning test. It's just really simple. We'll get some amniotic fluid, we'll put it on a slide, let it dry, and it basically has lots of protein in it and it'll crystallize under the microscope, and it looks like a fern. So this is positive sign for amniotic fluid, because obviously urine will not do that. They'll do a sterile speculum exam to see if there's amniotic fluids laying on top of the cervix. While she's pregnant, expectant management, we've got to rule out, is she infected? Is she becoming septic? We can give her prophylactic antibiotics, IV or PO. We can possibly induce if it's a really bad infection, or dissection her if the baby's doing horribly. And active management dependent on maternal and fetal distress. So I know you know in the med-surg world, the big thing is sepsis. So there's lots of sepsis protocols in med-surg. There's a sepsis protocol in OB, and you can see it once we see EPIC, and it's inside there. So for just simply presenting why she might become septic or have sepsis is because what? Typically in the OB world, it's prom. So check for signs and symptoms of infection or sepsis, vital signs. Always see how baby's doing fetal surveillance. And remember, the most common cause of fetal tachycardia is what? Maternal fever, because she's what? Septic. You can do a biophysical profile, a level 2 ultrasound on that baby, see what's going on with the baby. Of course, uterine tenderness, as you well know, and the discharge might be odorous. All right, we're going to go to dystocia. Dystocia means difficult. And I know you think, what in the world is that word? Long, difficult, or abnormal labor caused by the 5 P's of labor. So we are going to go through the 5 P's lightly. I know some of these words are very new to you, or some of these diagnoses. So I just want to make sure that you understand, always, always, always review again your normals. If you know your normal values and you get, oh man, I got an NCLEX question, you know, if you're given the data, you know, this is outside of normal value. So I'm going to emphasize a lot of normal values now. And then you can say to yourself, oh, well, that totally makes sense because it's not within the realm of normal. So let's talk about powers first. Dysfunctional labor, abnormal uterine contractions that prevent normal progress of cervical dilation, effacement, and maternal bearing down efforts. So the rate of descent is decreased, or a combination of these 3. Now let's just review before we even talk about these, is that I want you to write on this portion of your handout, while you're looking at your handout, you can think, oh my goodness, what is normal? And I kept on harping it, like, okay, remember, birth is imminent. And you want to write it here. When contractions, this is talking about powers, uterine contractions, you write right here, uterine contractions are coming. And you want to write it. Every 2 to 3 minutes is the frequency. Strength is 50 to 80 millimeters of mercury, or severe, right? Or upon palpation, it's firm. And Duration of the uterine contractions are 60 to 90 seconds long, a minute to minute and a half long. Frequency is every 2 to 3 minutes. Strength is 50 to 80 millimeters of mercury or severe. And duration is 60 to 90 seconds or a minute to minute and a half long. Anything outside that parameter, and you got a question, you're going, oh my goodness, it's going to be what? If it's coming every 1 minute, it's hypertonic. If it's above 80 millimeters per mercury, we wrote right here, it's hypertonic. I just wanted to simply present it that way. If it's coming, and she's dilated 10 centimeters, and she's coming like every 6 minutes, frequency, she's hypotonic. If she's dilated 10 centimeters, and she's only 25 millimeters of mercury, she's hypotonic. Do you understand that? So the frequency, right, would be a lot more sooner, more frequent, and it would be what? A lot more stronger. It would be like 100 millimeters of mercury. As opposed to hypo, it won't be what? It won't be hard enough. It won't be frequent enough. It might be coming every 5 to 6 minutes. And it might be only 25 millimeters of mercury. You see? So it's not strong enough. Hypo, hyper. And that's what I want you to zero in on. And always look at the physiology of the baby. The poor little baby sitting in there. It's like, if it's coming every 1 minute, that contraction, or if he's being squished, like 95 millimeters of mercury. Oh my goodness, right? So he's going to what? He's going to be stressed out. He doesn't have that time to what? Time for the uterine arteries to open up and to fill up. Baby's basically the baby because he's what? The uterine arteries are being contracted too often and too long. And that is why he's not getting enough O2. He becomes asphyxiated and he might poop in utero. Remember, normal. You should have no green babies on the labor table. Should never poop. In utero, should never poop immediately. And no yellow babies on the labor table. Should have no yellow babies, remember, immediately upon birth. He will be yellow after 24 hours, it says. That's physiological jaundice. So if it's coming too hard and or too fast, maybe it's severe tension. And then we find moms are very anxious. The first-time moms, they have an increased perception of pain. Of course you'll be exhausted, feeling out of control. So remember the bearing down efforts, primary and secondary. Secondary has a lot to do with this mom, how much she puts into it, right? Allow therapeutic rest, analgesics, right? To decrease pain, increase sleep, maybe rule out cephalopelvic disproportion. Maybe his head's too big on the baby. And regulate the Pitocin. Whereas the contractions are not going fast enough or strong enough. It's called inertia. You know, you've heard having inertia in summertime, right? It's weak and indentable, meaning when she contracts, it's not firm, it's not hard on her tummy, it's indentable. So we don't know all the time the cause, but maybe the babies are what? Transverse. Maybe his head's too big. Maybe the baby says there's too many inside. And then what we look at the mom, well, primary pair, that kind of covers all of them. Maybe she's tired. She doesn't want to push anymore. Maybe she's infected. Maybe she has psychological trauma. And the poor baby might be infected, possibly demise. So we will do ultrasound, make sure the head's not too big, Pitocin, and therapeutic rest. And inadequate voluntary expulsive forces, you're basically looking at the moms who just say they just basically don't want to push. They might say, no, I don't want to push. You're not making me push, and I just want a C-section. We're kind of relying on the primary powers of that wonderful what? Endogenous oxytocin coming from the posterior pituitary saying, okay, it's going to come out in your bloodstream and making that uterus contract. Sometimes, but their secondary powers are not there. They don't want to, or are ineffective bearing down. So what also can slow it down, of course, anesthesia, epidurals, spinals. Maybe she's too tired. Maybe she's exhausted. And the poor baby is asphyxiated. So coaching, again, it's huge. We're talking about coaching decreases what? C-section rates. Give her a favorable position and force it to vacuum if you need help, and a C-section if it comes to that. All right, let's go to the next video.